Hello, everyone. Thank you for joining us today for our webinar, Living with Bipolar Disorder, Why You Are the Most Important Member of Your Treatment Team. I would like to remind you all that if there's time, we will be answering questions at the end of the webinar. So if you are attending through Zoom, please ask questions in the chat box or the question and answer portion. And if you're joining us on Facebook Live, you can just leave a comment. Our presenter today is Dr. Frances Mondimore. Dr. Frances Mondimore is a psychiatrist with over 30 years of experience treating people with psychiatric disorders. A graduate of the Johns Hopkins University School of Medicine, he also did his psychiatric training at Hopkins, where he is currently an associate professor in the Department of Psychiatry and Behavioral Sciences. In 2012, Dr. Mondimore established the Mood Disorders Clinic at the Johns Hopkins Bayview Medical Center, where he led a team of clinicians specializing in the care of people with mood disorders until his retirement from clinical practice in 2019. Dr. Mondimore's research activities have included studies on the genetics of mood disorders and pharmacogenomic studies, as well as clinical trials of investigational treatments and medical devices for the diagnosis and treatment of mood disorders. He continues to be active in clinical research, including current studies at Johns Hopkins on the use of psilocybin for the treatment of depression. A co-author of numerous research articles, Dr. Mondimore is also the author of 5 books for general audiences on mental health issues that have been translated into 9 languages. These include Bipolar Disorder, A Guide for You and Your Loved Ones, the 4th edition of which will appear this fall, published by the Johns Hopkins University Press. Thank you so much for joining us today and presenting this webinar.
I'm very happy to be with you. Thanks for the invitation.
Of course.
Are we ready to go?
Well, let's hop right in.
Okay, good. Well, as I said, I'm very happy to be with you today, and I hope to share with everyone a little bit of guidance, some advice about living with bipolar disorder, and to make the point that the person being treated is actually the most important member of the treatment team. Let's get started with what we're going to cover today. I'm going to review a few bipolar disorder factoids for everyone, and then jump into some advice, some hints for living with bipolar disorder. I'm going to go through just a little bit of neuroscience, and it'll be very brief and very easy to understand. Don't panic, but it will make you much better able to appreciate the importance of the next section of the talk, where I'm going to present the elements of what I call mood hygiene. The most important one being sleep hygiene, avoiding alcohol and drugs, but there are quite a few other things as well. So this is rather old, some statistics from 1999, and it lists the causes of disability in the world. It comes out of the World Health Organization. And as you can see, in the top 20 causes of disability, 3 of them are mood disorders. Unipolar major depression being number 5, because it is more common than bipolar disorder, but you can see number 20 is bipolar disorder, and then number 17 there are self-inflicted injuries, which are almost exclusively seen in people with mood disorders. So this just makes the point that this is a very serious and very widespread health problem throughout the world. This is a little schematic illustrating the mood changes in bipolar 1 disorder, what we call bipolar 1, which is the classic manic depressive illness where people have full-blown severe major depressive episodes, as well as full-blown hypomanic and manic episodes, often with psychotic symptoms. Bipolar 2 disorder was thought of more as a research diagnosis until perhaps 15 years ago, but now is increasingly recognized as perhaps even more common than bipolar 1 disorder. These patients have full-blown major depressive episodes. They never get a full-blown manic episode, but do have periods of hypomania, which is a milder form of mania, where patients do not have psychotic symptoms, and they also have no mixed states. Then there are the soft bipolar disorders, which we are increasingly recognizing. These patients have mostly depressive symptoms usually, but there are a few bipolar features to their history. Perhaps they've had very mild and very brief periods of hypomania, perhaps only a day or even only a few hours. They have a family history of bipolar disorder. They have a history of becoming agitated or developing insomnia when they're put on antidepressants. These are just some of the features that indicate that a person with mainly depressive symptoms actually may be suffering from a bipolar disorder and therefore respond better to treatment for bipolar disorder than simply antidepressants. And there have been a lot of proposed subtypes of bipolar disorder beyond bipolar 1 and bipolar 2. And this slide shows what some of them have been, but I think the better way to look at this issue is that mood disorders exist along a spectrum. And on this slide, you can see all the way on the right are the unipolar depressions. These are patients who never have any symptoms at all of bipolar disorder, absolutely no manic or hypomanic symptoms. And then all the way to the left is bipolar 1 disorder. And you can see that there are just any number of variations on a theme here. And a lot of patients who respond well to treatment for bipolar disorder actually don't fit neatly into the DSM categories that many of you are probably familiar with. Bipolar disorders have a lifetime prevalence in the population of 1 to 2%. The male to female ratio is 1 to 1, unlike major depression, where women suffer at twice the rate of men. These epidemiological numbers are derived mainly from studies looking at bipolar 1 disorder, perhaps bipolar 2 disorder, and there are a lot of suggestions that if you add in the soft bipolar disorders, that percentage of 1 to 2% probably is much, much higher. Bipolar disorder is a very serious illness with a significant mortality rate. Persons with bipolar disorder are at risk for suicide attempts. A very important thing to remember is that a substantial proportion of people with bipolar 1 disorder have a substance abuse problem as well. And we know that co-occurring mood disorders and addiction actually multiplies the risk of completed suicide. And I also want to make the point that patients who are in mixed states, which are these poorly understood mood states where a person has the mood of depression, hopeless, despairing, but the physicality and the agitation and insomnia and sense of internal pressure that you see in hypomania and mania. So let's get right to the heart of the matter here, which is what role does the patient play in getting better? And I think that the most important step for the person with bipolar disorder to take is their complete acceptance of the diagnosis and their commitment to treatment. This is because the patient ultimately determines how well any treatment is going to work. It's the patient who puts treatment recommendations into action, decides whether to take medication, whether to take 50% of their dosing, 90% of their dosing. This is in the hands of the patient. And it doesn't matter how good the doctor is, if the patient is not taking charge of their treatment in this way. For patients who are taking lithium, it's very important that we have blood levels of lithium, which requires blood tests. And we know that that lithium works the best when the level is at a particular level. And that monitoring is very important. Patients who take lithium probably know that they should be getting their blood drawn as close to 12 hours after their last dose as they can. The level of lithium in the bloodstream rises and falls throughout the day, depending on the dosing of the medication. And so it's very important that we have a rule to follow on what time of day to get the blood drawn. And the convention that's been developed is 12 hours. So that means for most people that they should take their bedtime dose, 10 o'clock, 11 o'clock, whenever that might be, and then be at the lab at 10 or 11 the next morning. If they have a morning dose, it should be in their pocket or in their purse. And then they would take it after getting the blood drawn. Keeping appointments, of course, is vital. And being on time for appointments in order to get the full benefit of the full appointment time is also important. So these are all steps that are absolutely vital to successful treatment of bipolar disorder that are completely in the hands of the person being treated. And that means making a commitment. It means being an active participant in formulating a treatment plan with the providers, not passive, not simply been told, someone who's told what to do, but someone who will bring up whatever barriers there might be to treatment. This might be distance from the doctor's office. We now do a lot of telemedicine to take care of something like that. But for the patient to identify what barriers there might be to the treatment plan and work on getting rid of those barriers with the treatment team. It means taking charge of treatment implementation 100% of the time. It means making the decision that you will do everything possible to take control of this illness. Because if you don't, the illness will be in control and will be in control of you. It's deciding it's deciding to do whatever one needs to do to be as healthy as possible. And that means sticking with treatment and being frank and open with your treatment professionals. When I see patients, developing the treatment plan is always a conversation. It's not simply my telling people what to do. Bipolar disorder is a complicated illness. There are often many treatment approaches. Many of my patients will bring up a particular medicine that they've heard about or that maybe a family member has done well on. And I really encourage you to have those kind of conversations with the treatment team, because this is definitely an illness which requires a team effort. And one of the most important things, probably the most important thing in staying well with bipolar disorder and having a course of illness throughout one's life that is mild rather than severe is to prevent relapses. And of course, the most important way to prevent relapses is adherence to medication, but there are also a lot of other things that a person can do, and that's what we're going to talk about. Patients often show more environmentally triggered mood episodes earlier in the course of their illness, meaning that an episode of depression or an episode of mania will be triggered by some life event, a loss, a disappointment, some other severe psychological stress. However, the more relapses a person has, the more susceptible they are to having another. Patients can experience an acceleration in their illness as they age. We saw this much more before we had such good treatments for bipolar disorder, and patients would often have illness episodes more and more often as they age. To a large extent, we've been able to ameliorate that, and that's by better treatments and keeping patients better, preventing relapses. Because the more mood episodes an individual has, research has shown, they are actually more susceptible, more sensitive to stress, and that more minor stresses can trigger an episode. Patients with more episodes are more sensitive to stress. They are more likely to relapse under stress, and they relapse more quickly. However, the converse appears to be true. As time goes on and people have a longer period of time of mood stability, they appear to develop a resiliency to the illness, which can be very helpful. One of my mentors was very fond of saying that, for example, that the second year on lithium is better than the first. And that makes the point that as a person has a period of mood stability, they become more stable with time. A number of years ago, I was participating in a seminar with Dr. Kay Redfield Jamison, who many of you may know is on our faculty at Hopkins and suffers from bipolar disorder herself. And I was talking to residents during the seminar, and I quoted my colleague who said the second year on lithium is better than the first. And Dr. Jamison smiled rather mischievously and added, and yes, and the 23rd year on lithium is even better. So it makes the point that stability begets stability. So let's talk about a little bit of neuroscience now. I think it's helpful to understand a little bit of the biology of mood. What is it? How does the brain control mood and regulate mood? And also, what is the biology of stress and why does it matter? And I think understanding this will make it a lot easier to put some of these practices that I'm going to go over into place. One thing to remember is that we now know that the brain is actually a very dynamic organ. We used to think that by the time you were about 18 months old, you had all the nerve cells, all the brain cells you were ever going to have. And now we know that that's not true at all. That the stem cells, there are stem cells in the brain which are constantly developing into new neurons, new nerve cells, and that the existing nerve cells in the brain are constantly changing how they are connected to one another. Connections are weakened, connections are strengthened, but the brain is a very dynamic organ that is in a constant state of growth and remodeling. So what that means is that practices that are important for good general health are also very good for the brain. And we now know that mood regulation is something that depends on this very dynamic process going on in the brain. It depends on this continuous growth and remodeling of areas of the brain. And we know that a really important one is a section of the brain very deep in the brain called the hippocampus. Neuronal development and this brain area remodeling has been called plasticity or neuroplasticity. Plasticity is a word that means that something is able to be molded. And these areas of the brain are constantly remodeling themselves. And we now believe that it is an impairment in these processes, an impairment in neuroplasticity that is at the root cause of mood disorders. Mood regulation is therefore what we call an allostatic process. And if any of you have ever tried paddle boarding, like this young fellow is doing, I've not done it myself, but I've seen many people fall off paddle boards. And that's because when a person is on it and on the water, they are constantly readjusting their posture, changing the center of their balance in order to stay stable. In other words, they are completely they are altering their posture, their muscle tone continuously in order to remain stable. And the term allostasis, which comes from the words different and standing still, basically it means maintaining stability through change. And we believe that the change that's going on in the brain, the neuroplasticity, this remodeling effort, that is necessary in order to maintain a stable mood. So hopefully you've learned a new word today, a new concept, allostasis. We also know that brain areas actually shrink in people with mood disorders. And this shows a person or two people with unipolar depression. And we are able to picture certain areas of the brain now in living persons because of advanced imaging techniques. And as you can see on the left here, this is a normal hippocampus in a person without a mood disorder. And this is the shrunken hippocampus in a person with recurrent depression. And it's also been demonstrated that with treatment, the hippocampus actually becomes more normal in its size. So mood regulation requires two things. It requires neuroplasticity, which is this remodeling of neurons, of healthy neurons that is constantly going on. And it also requires what we call neurogenesis, which is the growth, the generation of new brain cells from stem cells in the brain. Both of these things are important for normal mood regulation, as well as regulation of a number of other things, including things like memory. So the implications for people with mood disorders is that they need to learn how to take care of their brain. And now I want to move on to the role of stress. As I'm sure many people listening and watching know, stress is a very important trigger for mood disorders and episodes of mood disorders. Stress is a worsening factor for many illnesses. There are many illnesses that are stress-sensitive illnesses. Asthma is one. Diabetes is one. Blood pressure is one. We know that stress makes these problems more difficult to treat. And that is certainly true for mood disorders. How do we know this? We know this from stressing animals and looking at the results of this stress on their brain. A relatively humane way to stress laboratory rats and mice is to confine them in a lucite tube in a brightly lit area. I mean, the rodents are timid creatures. They only come out in the dark, and this is experienced by them as very stressful. And when you subject rodents to stress, this kind of stress, over a period of time, it changes their brain. And here you can see the results. And you don't need to be a neuroscientist to recognize that that neuron on the right, which is a hippocampal neuron from a rodent who has had this kind of stress called chronic immobilization stress, that neuron on the right there is rather shrunken compared to the one on the left. And we know that stress has this very damaging effect on neurons in this part of the brain that is extremely important for mood control, the hippocampus. How does this happen? It happens through the stress hormones. And these are two other neurons from rodents. And the neuron on the left is a control. And you can see all of the nice branches here of this neuron. And then if you give rodents the rodent equivalent of cortisol, which is this human stress hormone, if you give them corticosterone, which is the rodent equivalent of cortisol, you can see that suddenly the neuron has lost many of its branches, that it's basically stunted. It looks like someone has pruned it. This was not a stressed animal. This was this animal who was given doses of stress hormones. Stress hormones are the messengers by which this kind of damage happens. We know that from rodent studies. So now I'm going to move into sort of the heart of the talk, which is to talk about mood hygiene. Hygiene is a word that we don't use very much in medicine anymore, not as much as we should. And it means conditions or practices that are conducive to maintaining health and preventing disease, as opposed to treating disease or curing disease. And for many years at Hopkins, I was in an office in the hospital that looked across the street to the front door of our Bloomberg School of Public Health. And you can see there that the school was originally called the School of Hygiene, Hygiene and Public Health. And this is because hygiene is a very important aspect of maintaining population health. We think of hygiene as mostly things like clean water, efficient sewage systems, and so forth. But hygiene also includes a lot of other practices that can be put in place to maintain health. And there is a set of practices which I call mood hygiene, which every person with bipolar disorder should learn about. I think of there being three important aspects to successful treatment of bipolar disorder, like a three-legged stool. And you can see that the three-legged stools, the three legs are medication, psychotherapy, and mood hygiene. And I think that these are almost equivalent as far as their importance in getting the best results from treatment. So what is mood hygiene? It's based on the knowledge that psychological stress, things like sleep deprivation, and also these physical stresses like sleep deprivation, lack of exercise, alcohol, drugs, even an unhealthy diet, they all raise the body's level of stress hormones, such as cortisol. And cortisol has a direct injurious effect on neurons, especially neurons in the hippocampus. We know this from rodent studies, and we also know that the hippocampus is damaged because in humans with mood disorders, because of the neuroimaging kinds of studies that we can do. So this means that whatever you can do to keep cortisol levels down is going to make it easier for your medication to work, to keep you healthy. Cortisol impairs neuroplasticity. It has also been shown to impair the development of new brain cells in the hippocampus neurogenesis. So what are some of these practices? I think one of the most important is sleep hygiene. And I'm sure many of you watching who have been treated for bipolar disorder have heard lectures from your therapist, from your doctor or nurse practitioner about sleep hygiene. Establish regular sleep habits, meaning retiring to bed and getting up at the same times every day. Avoid sleep disrupting habits. Cut down on caffeine. If you can cut it out, so much the better. No caffeine after noon is a good rule. Beginning to cut down by using half calf coffee, half regular coffee and half no caffeine. That's a nice way to get started rather than trying to go cold turkey. We know that exposure to light is a very important regulator of sleep. Our biological clock is actually about a 25-hour clock, not a 24-hour clock, and something needs to adjust it and reset it every day, and that something is exposure to bright light in the morning. So if we expose our eyes to bright light at other times of day, we are actually disrupting our sleep cycle. And the main culprit here these days are the screens that are ubiquitous in 21st century life. The phones, the tablets, the computers. And these screens are actually enriched with the blue wavelengths of light so that they actually in some ways mimic the morning light that is our get up and start your day signal. So obviously if you sit in bed playing games on your tablet, you're giving your brain a wake up signal when it's time to go to sleep. So I usually recommend no tablets after 7 o'clock. No screens after 7 o'clock. Avoid eating in bed or eating a large meal prior to going to bed. That increases blood sugar and is another signal to the brain to wake up rather than to go to sleep. Here's a set of things that are probably foreign to a lot of people with bipolar disorder. Folks with untreated bipolar disorder or poorly controlled bipolar disorder have to sort of grab at a period of good mood while they can, never knowing when depression is going to set in and throw off any kind of schedule. So they often learn to just kind of wing it as far as getting things done, waiting for a good time. That actually increases people's stress. And unstructured life is actually a very stressful life. And structure and schedules, while they may be a foreign concept initially to folks with bipolar disorder, they go a long way to eliminating the anxiety about worrying whether you're going to have time to do what needs to be done. So scheduling is important. Schedule whatever it is that you need to be doing in your week, housekeeping, paying the bills, mowing the lawn, whatever it is, have it on the schedule. A structured life is a much less stressful life. If you're a student, make regular study times, no cramming or all-nighters. This is not only stressful, but it also interferes with sleep. And we know that sleep deprivation is a very major trigger for mood episodes, especially manic episodes, and especially in individuals with bipolar I disorder. Exercise regularly. regular exercise is not only good for your muscles and bones and your heart, it's good for your brain as well. Why? Because it cuts down on cortisol. Regular exercise has been shown to help the body's stress system, which includes cortisol, be more tuned and to have lower levels of cortisol. So exercise is very important. I mean, there have been a number of studies showing that exercise actually has a antidepressant effect for a lot of people. And again, this is something to schedule. Schedule your daily walk or swim or your visit to the gym. Don't leave exercise to when you have the time or feel like it. Make it part of your regular schedule, not a luxury. Don't allow yourself to procrastinate. Putting things off until the last moment invariably increases your stress level. So what does this mean? It means not waiting to the last minute for things that have deadlines, like paying taxes, renewing your driver's license, getting your car inspected, all of these things that we have to do according to a deadline. Don't wait until the last minute. It increases your stress. If you eliminate procrastination as a way of dealing with things, you've gone a long way toward eliminating a lot of stress and keeping your cortisol level down. Another important thing is to not put off dealing with more weighty and perhaps more complicated sources of stress. And these might be things like relationship problems, conflicts at the workplace, conflicts with a neighbor or a landlord. These kind of ongoing stresses, disagreements will inevitably take a toll on anybody's mental health. But individuals with mood disorders are especially vulnerable to being destabilized by these kind of stresses. So it means really taking stock of these kinds of situations and stresses and conflicts in one's life and dealing with them. This is why psychotherapy is so important for so many people with bipolar disorder. Learning to live with the illness, learning to learn with the stigma, to live with the stigma of the illness. This is why psychotherapy is so important, and dealing with complicated or conflicted relationships or other life problems. Most of us can learn how to deal with problems better, and psychotherapy is certainly one of the very best ways to do that. But it might mean getting an attorney to help you. I always remind people of the Americans with Disabilities Act, which gives workplace protection to individuals. I have written many letters to bosses for patients to help them with their work issues, especially scheduling issues. For example, I've treated nurses who were asked to work night shifts or swing shifts. And this kind of sleep disruption is a very serious problem for people with bipolar disorder. So don't hesitate to get your therapist or doctor to write a letter for you or make a phone call for you. If anything in your workplace, your schedule insists on a schedule that would cause sleep deprivation. So these problems obviously require much more serious effort, more long-term effort, but the effort really pays off in staying well as far as bipolar episodes. Keep a mood chart. This is very helpful for the doctor. If you just Google mood chart, you'll come up with any number of them. This is one that was developed at Harvard. And you can see that it has all of these columns are different days. And the top part here, people mark what their mood is like. And this person has marked it at 2 different times of the day. You can also do it once a day. It also has places to mark the levels of anxiety symptoms, 0 to 3, and also periods of irritability. Another thing that's important for women is that the individual, the woman can actually circle the days of her menstrual period, and that makes it easy to identify the premenstrual period, where people often have exacerbations of mood symptoms, and that can be addressed often with hormonal treatments. It has a place for how many hours a person slept, and then a little section here with check boxes for checking off medication. And when a person's mood seems to be fluctuating and not responding to treatment well, keeping a mood chart like this for a month or 2 can really help to identify issues or stresses or something else that might be causing the problem. A lot of these mood charts also have a little place to actually leave comments and leave almost like diary entries for what went on a particular day, so that people can record some stress at the workplace, some stress in their personal life. So keeping a mood chart can be a very helpful technique to identify patterns. So summing up, mood hygiene is a set of practices that helps people to maintain health and keep their illness at bay. Very important aspects here of mood hygiene include establishing regular sleep habits, getting up and going to bed at the same time, and avoiding sleep disrupting habits, cutting down on caffeine, avoiding screens late in the evening, schedule your days, make time for exercise, and build in me time, build in relaxation time and unwinding time, so that you have time at the end of the day or an afternoon a week, whatever it is, that's your time to decompress and relax. Keep a mood chart. There are actually apps, many apps for the phone or tablets, where people can record their moods. And I've had quite a few patients who prefer this way to keep a mood chart. They may not be quite as detailed, but they nevertheless can be quite helpful. And then, of course, taking stock of the sources of stress in your life, job problems, relationship problems, worries about stigma. Therapy is the answer to that. And then, of course, not procrastinating. It is a recipe for worry. So this all makes the point that you really are one of the most important, if not the most important members of your treatment team, and a lot of getting well and staying better really is up to you. So I hope I've given you some enlightenment and some advice and maybe some help in doing that and staying healthy. And that's the end. Thank you very much.
Thank you. That was so wonderful. And I know that this was some really valuable information for our community. So we do have some time for questions. So I would like to open it up. And again, you can either ask if you're participating on Zoom in the chat box or question and answer portion, or if you're on Facebook Live, you can just leave a comment in the comment section. So we do have a few questions to start. This individual was diagnosed with bipolar disorder 2 at age 20, and they're 40 now. And they have significant family history of bipolar disorder going back, a few generations. They were wondering if it's recommended or helpful to get their diagnosis reevaluated. If, for instance, it might change from bipolar 1 to 2, or what your thoughts are on that.
Well, I would reference the idea of the bipolar spectrum again. We've come up with these categories, bipolar 1, bipolar 2, because they are fairly easy to define. But there are a lot of people who don't quite fit these categories very well. There are some patients with bipolar that seem to meet all the criteria for bipolar 1 disorder, but they don't respond to lithium very well, which is usually a classic character of, or a classic component of bipolar 1 disorder. And then there are patients with bipolar 2 disorder who respond better to lithium. So to some extent, bipolar 1 versus bipolar 2, it's almost an academic question. I think that each person with bipolar disorder is almost, each person almost has their unique form of the disorder. Sometimes we can lump people together, but sometimes people kind of fall in between. So having the diagnosis doesn't necessarily determine the treatment plan. It's a helpful way of thinking about these illnesses. It allows you to make a few predictions, but it's not an easy demarcation. When we were doing the genetic studies of families with mood disorders, one of the most important thing is deciding what the diagnosis is. You can't do genetic studies unless you have a really good way of deciding who has the illness that you're studying. And very often, when we were reviewing these cases, we would review them they were reviewed by two different research psychiatrists, and the two psychiatrists had different opinions as to whether it was bipolar 1 or bipolar 2. And there would often need to be a third person to make a tiebreaker. Again, these are diagnoses that are much more important when you're doing research, when you're reading research papers, but when it comes down to the individual person, finding what works for that person is much more of a trial, and developing a treatment plan is much more individualized and not dictated by a diagnosis of 1 or 2. So really the question is not so much, if things are not going well, if a person is having symptoms, the question is not so much, is my diagnosis 1 or 2, but rather my treatment plan isn't working, what needs to change in the treatment plan, not necessarily what needs to change in the diagnosis.
Yes, definitely. Thank you so much for that answer. So this individual shared that their family and friends don't understand bipolar disorder, and because of this, it's creating frustration and stress for them. What is the best way to educate others about your own mental health to relieve this stress?
Right. That's a really great question. And yes, so many families really don't understand this illness. And I think the way to combat that is to educate them. I mean, basically they have to be open to receiving accurate information about bipolar disorder. I noticed on the website, the Foundation's website, there's a lot of good educational materials. I have written a book on bipolar disorder that has a whole chapter devoted to family issues and helping with family issues. Of course, therapy and perhaps a family therapist is very important. I always encourage patients to bring family members to their appointment so that the family member feels that they are being heard, that they can share observations that perhaps the patient doesn't feel comfortable sharing or maybe isn't aware of. You know, so very often a patient will say, "Well, can I bring my wife along?" And my answer is always, "Yes, I need all the help I can get to understand your problems and come up with a good treatment plan." So the family is usually the family is always a very important part of treatment. They are impacted by this illness very much, and as I said, they need to feel like they are heard as well. So one way to help with that is to actually bring family to therapy sessions, or at least to the doctor's sessions. There are also meetings, support groups, support meetings in the community, and bringing family members to those are helpful as well. And as I said, there's lots of reading material. You can go to the National Institutes of Mental Health, and they have short brochures and so forth that are very introductory. Places like the Foundation's website, the other Medscape is another website, WebMD. These websites all have information, and I think that the very best way to understand is to be informed.
That is some really, really wonderful advice. We wholeheartedly believe that education for the individual and the individual's family and loved ones is so important.
Yeah, I often quote the motto of the Johns Hopkins University, what you see on the seal of the university. It says "Veritas vos liberabit," which is a Latin motto, and it means the truth will set you free. And I think that that's how I think about educating people about this illness, that when they understand the truth, when they understand what they're up against, it will really help them to control the illness and to do much better.
Yeah, that is a wonderful motto. So this is another question that's kind of along the same lines. As a caregiver, how can you communicate this information to your loved one who may be resisting treatment or is really struggling to get treatment, so that they feel encouraged to be the most important member of their treatment plan,
Right.
if they might not be prioritizing that?
Yes. Well, I think, you know, to put it in the most succinct form, as I've said a little bit earlier today, take control of this illness. Do everything you need to do to take control of this illness, because if you don't, it will control you. So whatever that means, it means, of course, being in treatment, taking medication, doing all the things that I said need to be done. But acceptance of the diagnosis and commitment to treatment are absolutely vital to do well, to do better. And again, all of the other things that I mentioned are helpful. Reading materials, going to the websites. There are lots of websites that are patient-centered, and you know, I have a number of patients that have their own websites and do chats and so forth. that help people to feel that they're not alone in dealing with this problem. And there are support groups in the community. So things have changed so much. I mean, in the old days, this was not something that people even talked about. And now there are so many resources, so much support out there that people can take advantage of. And I just really encourage them to do that.
Yes, definitely. There is a lot out there for people to utilize. So I'd say that is all we have time, all the time we have for questions. So if you have any additional follow-up questions, you can email me at info@ibpf.org. So thank you again, Dr. Mondimore, for sharing such a wonderful presentation with our community. This webinar will be available on our website and our YouTube channel. And so I invite you all to visit www.ibpf.org, where you can learn more about our upcoming webinars and to stay connected via our monthly e-newsletter, where this recording will be featured. And we will also be including Dr. Mondimore's website in our website on our website's advertisement for this webinar, so you guys can go check out more of the offerings and educational pieces that he shares as well. So we thank you all for attending, and we wish you a wonderful week. Bye, you guys.